Hello and welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson, and I'm one of the GP Notebook study group presenters. In this episode, we'll be taking an overview of alopecia, and this topic has been requested by one of our GP listeners, so many thanks for this great suggestion. Hair loss is one of the most common reasons patients seek advice from GPs and dermatologists. And while alopecia is rarely a life-threatening condition, its impact on self-esteem, confidence, and quality of life can be profound. Now, for clinicians, the challenge is that alopecia isn't a diagnosis in itself, but rather it's a clinical sign that can arise from a wide range of underlying conditions. Some forms are temporary and completely reversible, while others lead to permanent destruction of hair follicles and irreversible hair loss. And distinguishing between these possibilities early is critical for achieving the best outcomes. So in this episode, we'll be taking a broad look at the major types of alopecia, discuss practical approaches to diagnosis, and review current management strategies that can help us as clinicians navigate this complex and often emotionally charged area of medicine. An important concept to start with, though, is that when we evaluate a patient with hair loss, our first question should not be why is their hair falling out. The first question should be whether the alopecia is scarring or non-scarring, since this distinction then guides almost every subsequent clinical decision. So, in non-scarring alopecia, the hair follicles remain intact, and although patients may experience significant hair loss, the follicular structures are preserved, meaning that regrowth remains possible. In contrast, though, scarring alopecias involve permanent destruction of the hair follicles, and once that process has occurred, the hair can't regrow because the follicle itself has been replaced by fibrotic tissue. And recognizing this distinction early can mean the difference between preserving hair and losing the opportunity to intervene effectively. So, looking at non-scarring alopecias first, androgenetic alopecia is by far the most common, and we'll all be familiar with the classic patterns here. Men typically develop recession of the frontal hairline, accompanied by thinning at the vertex, whereas women, on the other hand, usually present with diffuse thinning across the central scalp while largely maintaining their frontal hairline. Now, although often viewed as a cosmetic concern, androgenetic alopecia is in fact a biologically complex condition involving progressive miniaturization of hair follicles. So over time, thick terminal hairs gradually transform into finer, shorter hairs, and the growth phase of the hair cycle becomes progressively shorter, resulting in diminished hair density. Now, genetics plays a significant role here, particularly in male pattern hair loss, where androgen sensitivity and the effects of dihydrotestosterone contribute substantially to disease progression. In women, though, the picture is somewhat more complex, and hormonal influences appear to interact with genetic susceptibility in ways that aren't yet completely fully understood. From a clinical standpoint, androgenetic alopecia is often diagnosed through careful history and examination, and dermoscopy can be particularly helpful here, revealing variability in hair shaft diameter and increasing numbers of miniaturized hairs. Now, the encouraging aspect of androgenetic alopecia is that treatment options continue to expand. So, topical minoxidil remains a cornerstone of therapy for both sexes, while oral finasteride continues to play a major role in appropriately selected male patients. Additional interventions, including platelet-rich plasma, low-level laser therapy, and hair transplantation, have all broadened this therapeutic landscape considerably. Now, another condition that we should all recognize in this group is alopecia areata. And unlike androgenetic alopecia, alopecia areata is an immune-mediated disorder, and patients often describe waking up one morning and discovering a discrete patch of hair loss that has seemed to appear overnight. And this sudden onset can be alarming and often generates significant anxiety in these patients. On examination, the affected skin usually appears smooth and healthy, and there is no scarring, scaling, or significant inflammation. But one of the most distinctive findings here is the presence of the so-called exclamation mark hairs at the edge of active lesions. And these short, tapered hairs are highly suggestive of the diagnosis. It can affect individuals at any age, including children, and while many patients experience only a single episode, others can follow a relapsing and remitting course, with a minority developing extensive scalp involvement, known as alopecia totalis, or complete loss of body hair, referred to as alopecia universalis. The underlying pathophysiology involves disruption of the immune privilege that normally protects hair follicles from immune attack. And so once that protection is lost, inflammatory pathways target the follicle and interrupt normal hair growth. Now, management depends on the disease severity. Limited disease often responds well to topical or intralesional corticosteroids, whereas more extensive disease may require systemic therapy. And in recent years, the emergence of JAK inhibitors has generated considerable excitement, offering new treatment possibilities for patients with severe disease. Now, one particularly important aspect of caring for patients with alopecia areata is acknowledging its psychological impact. And for many patients, especially children and adolescents, the emotional burden may exceed the physical consequences of the disease itself. Then there's another very common cause of hair loss we see in our surgeries, telogen effluvium. And this condition often presents quite differently from what I've already mentioned. So rather than patchy hair loss or patterned thinning, patients here typically report diffuse shedding across the entire scalp. So a common clinical scenario here would be a patient who presents with handfuls of hair in the shower drain or on their hairbrush, and they're understandably distressed and frequently fear they're going to become permanently bald. Now, the key to understanding this particular alopecia lies in the hair growth cycle. So under normal circumstances, the majority of scalp hairs remain in the growth phase known as anagen. And when a significant physiological or psychological stressor occurs, a larger than normal number of follicles then prematurely shift into the resting or telogen phase. Now, very importantly, hair loss doesn't occur immediately. There's usually a delay of around 2 to 3 months between the triggering event and the onset of shedding. And this delay can often complicate the diagnosis because patients may not initially connect their hair loss with an illness, surgery, childbirth, major emotional stress, nutritional deficiency, or medication exposure that occurred several months earlier. So always ask them if anything significant happened in their lives 2 or 3 months earlier. Fortunately, telogen effluvium is generally reversible, as once the trigger is identified and addressed, normal hair cycling resumes. But I do think counselling is essential because patients often expect an immediate improvement, whereas in reality, shedding may continue for another several months, and cosmetically meaningful regrowth may take a year or longer. Now let's have a look at the scarring alopecias. Although less common, these disorders demand prompt recognition because permanent follicular destruction can occur before the diagnosis is established. And two of the most important entities here are frontal fibrosing alopecia and lichen planopilaris. Frontal fibrosing alopecia most commonly affects postmenopausal women. Patients typically develop a slowly progressive recession of the frontal hairline that may initially be mistaken for normal aging, with eyebrow loss also being another common feature and which may precede scalp involvement. Some patients can also report itching, burning, or discomfort, but many remain asymptomatic despite ongoing disease activity. Lichen planopilaris, on the other hand, often presents differently, so patients may develop irregular patches of hair loss, particularly on the scalp vertex, accompanied by perifollicular redness, scaling, itching, or tenderness. Now, what makes these conditions particularly important is that the inflammatory process targets critical stem cell populations within the follicle, and once those cells are destroyed, regeneration becomes impossible. So as a result, the primary goal of treatment in these cases isn't hair regrowth. Instead, the focus is on halting disease progression and preserving remaining follicles. So this brings us to the practical evaluation of patients presenting with alopecia, and is so often the case in medicine, a thorough history remains the foundation of diagnosis here. We should determine whether the patient is experiencing visible baldness or excessive shedding, the timing of onset, speed of progression, pattern of hair loss, any associated symptoms, medication history, nutritional status, family history, recent illnesses, surgeries, and psychosocial stressors can all provide valuable diagnostic clues. And physical examination should extend beyond the scalp. Assessment of the skin, eyebrows, eyelashes, body hair, and nails can all reveal findings that point towards specific diagnosis. And the scalp examination itself deserves careful attention. Adequate lighting is essential, and dermoscopy has become an indispensable tool here in modern hair clinics, since many characteristic findings simply can't be seen with the naked eye. The old-school hair pull test still retains clinical value here. So, by gently pulling a group of hairs from multiple scalp regions, we can gain insight into active shedding and disease activity. When the diagnosis remains uncertain, laboratory investigations may be warranted. Iron deficiency, thyroid dysfunction, vitamin D deficiency, and other systemic conditions can all contribute to hair loss, and so should always be considered when clinically appropriate. And in my experience, undiagnosed hypothyroidism and very low levels of vitamin D are much more common than we often realize in these patients with alopecia. Scalp biopsy remains particularly valuable in scarring alopecias, where histological examination often provides definitive diagnostic information. Now, an important principle here is avoiding a one-size-fits-all approach, as hair loss represents a symptom with many potential causes, and so management must be tailored to the underlying diagnosis. I find that patients are often surprised to learn that successful treatment requires patience. Hair growth is inherently slow, and even highly effective therapies may take months before visible improvement occurs. So setting realistic expectations early can dramatically improve treatment adherence and patient satisfaction. Finally, it's always worth discussing the psychosocial dimension of alopecia. And as healthcare professionals, we may sometimes underestimate the emotional impact of hair loss. Now, while the condition may not threaten physical health, it frequently affects identity, self-image, social interactions, and psychological well-being. Women often report significant reductions in self-confidence and social engagement. Children and adolescents may experience bullying, embarrassment, or social isolation. And even adults who appear outwardly resilient may struggle privately with anxiety or depressive symptoms. And for this reason, our effective management extends beyond prescriptions and procedures. Empathy, reassurance, patient education, and psychological support should all be considered integral components of care. Advances in immunology, genetics, and regenerative medicine are also creating new opportunities that were unimaginable only a decade or so ago. So I think for us as clinicians, the key message here is a simple one. Approach alopecia systematically. Determine whether the process is scarring or non-scarring. Perform a careful history and examination. Use dermoscopy and investigations judiciously, and recognize the substantial emotional burden these conditions often carry. And by combining diagnostic accuracy with compassionate care, we can help our patients navigate not only the biological consequences of hair loss, but also its profound psychological effects. So that's an overview of alopecia, and I do hope you found this podcast helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Feel free to get in touch with us via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts, as in this case. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.